All right, well, first I just want to thank everybody for coming. Obviously we're here to talk about anterior hip replacement, how it's different from conventional hip replacements, and basically for people to understand that you have a choice in how your hip's replaced, and that can affect your recovery. So our agenda tonight, again, we're going to discuss some of the problems that end up requiring hip replacement, the different approaches that are used typically by surgeons to replace a hip, and how anterior hip replacement is different, the recovery after anterior hip replacement, and then the hospital experience. So osteoarthritis is the most common cause for the need for hip replacement. Hip arthritis for ages over 45, the rate is about 28% of people. It's a little bit higher in females, 29.5% in females and 25.4% in males. And basically arthritis is deterioration of the joint cartilage, and that leads to bones rubbing on bone and ultimately pain and limited mobility. This is an x-ray that basically just illustrates a normal joint, and you can see here that there's the edge of the ball, the edge of the socket, and there's a good bit of space in between, and that's usually filled with cartilage. So that's a nice, normal, healthy hip. On this other hip, you can see there's no space at all, and so it's hard to tell where the ball stops, the socket starts, and so there you have bone on bone, and that's a person that would need a hip replacement. Causes of osteoarthritis, again, it's excessive wear of the joint. That can come from joint injuries from sports or other high-impact activities. It can be age-related, although osteoarthritis does not occur in all people as they age. Obesity, especially with osteoarthritis of the knees, small deformities in the bones and joints, and then work-related activities or accidents can lead to arthritis in the joint as well. Another condition that can lead to a person to require a hip replacement is avascular necrosis. That's basically like a stroke to the ball of the hip. So for some reason, the blood supply to the ball gets disrupted and that area of that bone dies. Typically, it's more rare than osteoarthritis, and you can see that as many about 20,000 people a year will develop AVN. Again, that leads to collapse of the bone in the joint and the joint destruction, causes pain and limited mobility, and it usually deteriorates pretty rapidly once it happens. You can see the difference in the hips here compared with the arthritis ones we looked at just a minute ago. You can see how deteriorated that is. The ball's not really round anymore, and all of that bone is just collapsed and crumbled down. So that obviously is a pretty painful condition that would require a hip replacement. So how do we know you have hip arthritis or AVN or a problem that might require a hip replacement? Basically, we kind of listen to your history. When do you have pain? What causes it? Your physical exam. And then usually x-rays are the main thing to get to determine whether a hip replacement is what you would need. Occasionally, for AVN or other problems, you may want to get an MRI to help diagnose that. Once you've been told, okay, you have arthritis, avascular necrosis, or one of these problems that require hip replacement, your options are either non-operative treatment or surgical treatment, which would be a hip replacement. When we talk about non-surgical treatment, you can do medications, usually recommend over-the-counter medications or anti-inflammatory medications such as Advil or Tylenol. Exercise and therapy can be helpful, and then assisted devices as the pain gets worse, either a cane or walker. When we talk about the medications, again, anti-inflammatory medications are probably the best thing to take. They help decrease the inflammation in the joint and can help improve pain. Glucosamine and chondroitin is a over-the-counter supplement. It tries to replace the natural components of articular cartilage. The thought is if you supplement your body with it, sometimes that can help regrow cartilage. I'm not sure that it can do that, but it may help slow the progression of arthritis. But I find it's about 50-50 whether it does help patients, but it's definitely something you could try if you're looking for anything to avoid surgery. Steroid injections can be helpful to decrease the pain from hip arthritis, but usually they are limited in how long they last, and so they just try to buy you some time before having to have surgery. So surgical treatment for hip problems is really what you want to use when everything else has failed, when the pain becomes intolerable and narcotics are required to tolerate the pain, or if the deformity becomes too great, like the x-rays we saw with avascular necrosis. So when we talk about surgery for a hip replacement, there's really two options at what you could do. Obviously a hip replacement, which is what we've been talking about. Typically hip replacements last longer. And then when you do that by an anterior approach, it's definitely less invasive. There's also hip resurfacing. There are some physicians in Columbia who believe hip resurfacing is the best thing for most patients. I'm not a huge fan of that. And there's multiple reasons why hip resurfacing is not as good as a total hip, especially when you combine it with an anterior approach. And when they advertise hip resurfacing, they'll tell you it's a less invasive procedure for treating the hip arthritis. And that's true to some degree in that as we look at these pictures, this is a total hip implants. And so you can see with a total hip, you cut the ball off and replace it with the prosthesis. This is a hip resurfacing implant, and so instead of cutting the ball off, you basically put a cap over the ball. You still replace the socket, just like you would with a total hip. The problem is in order to do a resurfacing, you have to dislocate the hip, which means you have to cut pretty much every muscle away from the femur or the thigh bone in order to resurface it. So that in of itself is maximally invasive, and they won't usually tell you that, but that can create a lot of problems for you later when you have to have a hip replacement. Also, the hip resurfacings are all metal on metal. And there's problems with metal on metal implants. As the metals rub together, metal particles are broken free. Those can go into your bloodstreams, and what they may cause down the road, there's concern for whether that would cause cancer. That's a potential problem. And if you look at all the attorney commercials on TV that talk about hip recalls, those are all from metal on metal components. So hip resurfacing in my mind is not necessarily the best thing for one because of the metal on metal as well. Again, it's not truly less invasive because of how much muscle you have to cut. Typically, they only last you about 10 years. They're good for somebody who may have a problem in their 30s and you're trying to buy them 10 years before having total hip. But pretty much if you're in your late 40s, 50s, 60s and on, you can have a hip replacement. It's going to hopefully last you at least 30 years or more. And it's a lot easier to get over than a hip resurfacing. And then for patients who have osteoporosis, so an older patient whose bones are a little bit weaker, because you're putting a cap over that ball, it creates a lot of stress on the neck of the femur, and those patients have a very high risk of femoral neck fracture after resurfacing. So multiple reasons why I wouldn't recommend it unless somebody was in their 30s, and so it's more of a rare situation that I would recommend it. But there are doctors that are around that will put a resurfacing in just about anybody because and a lot of it's financially driven why they do it, but I'm not a big fan of it, and especially you can get over a hip surgery a lot quicker with the anterior approach with a total hip. This is just an x-ray where the patients had a resurfacing on one hip, and this is a total hip on the other. So, with regard to the amount of metal that's in there, it's less invasive, but the problem is this is going to wear out in about 10 years. Or if you have osteoporosis, like I said, you can break through here because there's so much stress from that on that femoral neck, and a lot of patients will get a stress fracture of the femoral neck, and that'll lead to a need for a total hip at that point. So when we talk about hip replacement surgery, what most people don't understand is that there are multiple ways that you can perform a hip replacement, and most surgeons won't even discuss that with you because they only usually do it one way. And the approach that's used greatly affects a person's recovery and their outcome. So patients, referring family physicians, they all need to know the difference between those approaches because it makes a difference with the recovery afterwards. And so what you need to understand is you have a choice. You don't have to settle for what one particular doctor, what approach he does. You have a choice in how your hip's replaced, and you need to research that, find out what's best for you, and make that decision to do that. You don't want to settle for approaches that can affect and slow your recovery. You can recover faster, get back to your active lifestyle quicker, and you want to make sure you're happy with your hip replacement. You don't want to be like the horse here saying, I'm not really pleased with my hip replacement. You want to be happy with it. All right, so when we talk about the different approaches for hip replacement surgery, the posterior approach, it's the most commonly used approach by most surgeons. Part of the reason for that is it's technically the easiest, because it provides complete exposure to the hip joint. You can see on these pictures, it's usually a pretty large incision on the back part of the hip, but there's multiple muscles that cover the hip joint, and you have to cut through all of those in order to replace the hip. This is just another picture of an incision from a typical posterior approach. Pretty long incision. Again, have to cut all the muscle underneath. You have to be careful. There are some physicians that do what they call a minimally invasive posterior approach, and all they do is they just make a really small incision and say it's minimally invasive, but they still cut all the same muscles underneath. So they're just kind of trying to hide it with a smaller incision, but the damage done to the muscle is still the same. All the risk and potential problems of a posterior approach are still there. Posterior approach has usually the longest recovery, and it's also the most painful because you have to cut more muscle. Other approaches are a lateral or anterior lateral. Those are very similar. Again, those have to cut muscle. You can see if you came from the side or back of the hip, all these muscles you have to cut through in order to get to the hip. After hip replacement with a posterior approach, even lateral approaches, there are hip precautions. You can't bend your hip past 90 degrees. You can't turn your knee or foot inward. You can't cross your leg past the middle of your body. And so all of these are activities that you can't do after a hip replacement by posterior approach. And if you look at those are pretty much normal activities that you would do just to function. And so if you say, well, you can't do these things, that makes it really hard for people to function after a posterior approach hip replacement because you put so many limitations on them. With the anterior approach, you can do all of these things. And so you don't have those limitations or precautions that you would with the posterior approach. And so that in of itself makes the recovery a lot easier. So anterior hip replacement, it's the only true minimally invasive hip replacement surgery that exists. You do not cut any muscle. You just go in between the muscles. You spread those muscles apart and the hip joints right in front of you. This is just a diagram showing the back side of the hip here, and it's completely covered in muscle. And this is the front part of the hip, and you can see you got a little small muscle here, and then there's really nothing there. You got a space where you can go in between to get to the hip joint, and so you don't have to cut the muscle. The other benefit with anterior approach is just the amount of soft tissues there. This is the exact same patient. They had had a hip fracture previously and had a plate and screw on the outside of their hip, and they needed a hip replacement. So this is the incision that was used to take out the plate, which would be your typical incision to do a posterior approach hip replacement. There's over 5 inches of fat on the outside part of the hip. The incision here for the anterior approach, it's a much smaller incision, and there's really less than 1 inch of fat on the front part of the hip. So it's just a lot less tissue damage, even from just the general subcutaneous tissue between coming from the side versus coming from the front of the hip. When we talk about the incision itself is pretty small. It's only about 7 centimeters inside, which is about 2.75 inches. It's right on the front part of the hip. These are the bony landmarks of your pelvis, and then the outside of your hip, and it's kind of centered in between there, about 7 centimeters in length. But I tell people I can make your incision a foot long. It really doesn't matter. It's not the incision size, it's what's done underneath. And because we don't cut the muscle, that's what makes the difference in the recovery. To do anterior hip replacement, it's made easier with this use of this special operating table. There's very few hospitals that own this table. In South Carolina, Newberry Hospital is one of them. And it just allows you to gain access to the hip and be more controlled and just make the surgery a little bit easier. A lot of places don't own it, one, because they don't have surgeons that do anterior approach, but also it's a pretty expensive table to own as well. Another benefit of anterior hip replacement is be able to use live x-ray during surgery. Because the patient's on their back and on this special table, you can use an x-ray machine to view the hip. That's really important for making sure that the components we put in after hip replacement are in the most accurate position possible. And why that's important is if the components are placed very accurately, it allows them to last longer. If you had a tire on your car that was not straight and you drove for 10,000 miles, that tire is going to wear out a lot quicker, versus if the tire is perfectly straight, you'll probably get 50, 60,000 miles out of it. So you want to make sure those components are placed perfectly, and you can only do that with the anterior approach. And so we make sure everything's placed perfectly, and hopefully that hip will then last you twice as long as what it would if you didn't have the x-ray. Also, we can use the x-ray to judge leg length. So sometimes with hip arthritis or AVN, one leg may be shorter than the other, and usually we can use the x-ray to measure that and then adjust leg length to balance people back out to get their legs the same length. When you do it by posterior approach, that can be a lot harder to do because you cut the muscle, so the normal tension on the hip isn't there anymore, and so you find with posterior approach it's very common to lengthen a leg, to try to gain stability, but also because you can't really judge the actual length of the two legs. This is just an x-ray of using the x-ray during surgery. We're comparing the hip we're replacing with the other hip so we can judge leg length and make sure that the legs are the same length, and this would be just a final x-ray of the hip replacements afterwards. So when we talk about recovery after hip replacement by anterior approach, typically the hospital stay is 1 to 2 days. Probably about 70% of patients go home the next day after having it done. I have had patients go home the same day. I don't rush anybody out of the hospital. We kind of use it as when a patient feels comfortable to go home, we let them go home. But typically that comes out to about 1 to 2 days, which is usually a couple days sooner than you would if you had a posterior approach. Usually most people after hip replacement, they use a walker for about 1 to 2 weeks, then a cane another 1 to 2 weeks after that. So usually between 2 to 4 weeks, depending on the person, after surgery, they're walking good, they're getting around well, but they still have a little bit of swelling, a little bit of soreness to the hip. And that usually resolves after a few months. But most people are able to return to most normal activities by 6 weeks after surgery. Again, the advantages when you just compare posterior approach or conventional surgery with the anterior approach, you can just see the hospital stays a lot quicker, smaller incision size, but the biggest thing is there's no muscle cutting or detachment, and that's what makes a difference with the faster recovery. Reduced pain, reduced blood loss, reduced tissue healing time. So a little bit about me. I'm a Newberry County native. I grew up in Newberry County in South Carolina. I came back home to be closer to my family. We currently have offices in Clinton and Newberry, South Carolina, and we're also currently building this building here in Chapin to get a little bit closer to the Columbia area. I've been performing anterior hip replacement for almost 11 years now. I was the first surgeon in South Carolina to perform it. And by this point, I've performed well over 1,000 anterior hip replacements, and I exclusively perform anterior hip replacement. I don't do it any other way because I believe it's the best way to do it. You'll find some surgeons that may do it on certain people, and they're not really committed to it. That's somebody who is not comfortable with the procedure and doesn't truly believe in it. But I do it on unless there's some reason anatomy-wise why they can't have it done. Everybody gets an anterior hip replacement because it's the best, and everybody deserves to have that benefit. I do perform my surgery at Newberry County Memorial Hospital. It is a smaller hospital, but I think it's probably one of the best hospitals in the state, or the best. It's one of the few hospitals in South Carolina that had the special table that we showed to be able to perform it. And over the last few years, we've really worked hard to develop a pretty amazing joint replacement program, and as a result, they've won numerous awards from Health Grades for their joint replacement program, and they've also been ranked by Health Grades as #1 in the Midlands. So they beat out pretty much every hospital in Columbia and in the entire Midlands, and I think they were #2 or 3 in the state for joint replacement when that rating came out. So at this point, I'm going to turn the talk over to Kay. Kay's from Newberry Hospital. She's going to talk a little bit about their Back on Track program and the joint replacement program they have there, and then I'll take back over after that.
All right, so at Newberry Hospital, we have a joint program, and we call it Back on Track.
Yep.
Our program's designed to assist patients before surgery, during surgery, and after. We want to make sure you all know what you're getting into when you go to have this surgery. We try to make it fun. We adopted the running track theme. You're the runner as the patient, and then we're the coaches, and then whoever you have at home, whether it's your spouse or your other family member, they're your cheerleader, and they're there to cheer you on, to keep doing your exercises, to keep doing your therapy. So that's kind of the way our program works. Our mission is we want to provide exceptional health care with a personal touch, and we truly at Newberry Hospital do provide that personal touch to our patients. Our vision is we want to be the orthopedic service provider in our region to have that excellent care to our patients with a high state of technology and highly trained staff. We developed a plan to have consistent care. Our healthcare professionals are excellent at what they do. They're committed to providing excellent patient satisfaction, and we're always striving to improve. So we're always asking you all as patients, what can we do to improve our services? How can we get better? Some of our staff members are shown up there with their smiling faces, and we have some of those here tonight with us. We use that patient-centered care model. Patient satisfaction is our ultimate goal in our Back on Track program and throughout our hospital. The staff introduce themselves using the AIDIT concept, where we acknowledge you all as the patient. We introduce ourselves, we tell you what we're going to do, how long it's going to take, explain those things to you, and thank you for choosing us for your healthcare needs. And at each level, you'll see whether it's the therapist or the nursing staff talking to each other, giving a report on you as the patient so they know what's going on. The therapist is going to go to the nurse before they come to your room and say, how's Miss Jones doing today? She's doing great. They talk to each other. When you come up from surgery, that surgery nurse is going to give the nurse report on the floor so that they're aware of how you did during surgery. Clinical care, our physical therapy and occupational therapy are great. They utilize the standardized total hip protocols. You're going to get up the day of surgery, if at all possible. You're going to take 5 steps, or you're going to walk 5 feet or 100 feet. Depends on you as the patient, depends on how the anesthesia wears off, but a lot of patients are up ambulating that day of surgery down the hallway. And as Dr. Logan said, some of our anterior hips have been discharged the day of surgery, so they're doing such a great job that they're ready to go home that afternoon. We also make sure you can do steps before you go home. You can walk up those steps, and you can get in and out of the car. In our gym, we have a car there, so you can practice getting in and out of the car, and our therapy staff do a great job at that. We do provide a class for you all if you schedule yourself for surgery, the first and third Wednesday of every month at 11:30, and we encourage our patients to come to that class. That gets your knowledge up, tells you what to expect, what you're going to need when you go home, all of those things. And our case management staff also help to prepare that after the hospital. Our highlights, as Dr. Logan talked about, we are very proud of all of our awards that we have won, and we are certified by Joint Commission for our total hips and knees. So it's 2 programs for hips and knees that we are certified. But the staff members truly make up how our hospital functions and the patient satisfaction that we have. We do have that personal touch there. Any questions? We have a table at the back. I'll have cards back there if you have any questions about the hospital or any concerns. We're open for you to come in and take a tour of our facility to know what type of hospital we have.
All right. Well, so I can tell you how great it is, but it means more when you hear it from somebody who's actually had it done. So I do have 2 patients here tonight that are going to come up and just kind of tell you their experience with anterior hip replacement and their experience with the hospital. So first I've got Ann Piercy. I'm going to ask her to come up, and she's going to give us her experience. And
no cane.
No cane.
No cane. And I think, what did we decide on, just 4 weeks out?
Yeah, she's only 4 weeks out after her hip replacement, so she's pretty recently had it done and is doing great.
It's because I'm a good doctor.
Well, thank you. I'll put that on.
Thank you. Somebody asked me how in the world did I hear about Dr. Loggins in Newberry. My neighbor across the street is a nurse at Baptist Hospital, and her mother had just had surgery here with one of the local doctors, and I called and if I didn't mind waiting 10 years, I could get an appointment with one of them. It's just unbelievable how long it takes for the few that do this procedure. So she told me about Dr. Logan. So I called and made an appointment, and from the time I had my appointment, where are you? Right. When I had my appointment with him till my surgery was 3 weeks. And the class that they had beforehand was so informative. You know, people are scared to death, just the idea of surgery. And a lot of us tend to put things off, and I think I had pushed it to the end. But that was so good. And the first time I saw Dr. Logan, he looked like he was 12 years old. And he told me that he was the first doctor in South Carolina to do this procedure. So that impressed me a lot, that this guy's done this a few times before. But anyhow, I was set up within 3 weeks of my first visit with Dr. Logan. And I just can't tell you about this hospital. It's this little tiny hospital in a little tiny town, just 40 miles up the road. I've never had such care in a hospital as I got in Newberry. And this just impressed the living daylights out of me. I can't ever say his name, but the anesthesiologist came to see me the next day after my surgery to make sure that everything went like he told me it was going to go. And how many of us ever see the anesthesiologist after the surgery? Usually they'll put you to sleep and that's the end of it. But the nursing staff, the housekeeping staff, the people that delivered the meals, and Dr. Logan, I don't know if you know this, but your other doctors in your practice, 2 and 3 times a day they would come by and check on me, and I just thought, wow. You know, usually you might see a doctor once a day if you're lucky, but I just can't say enough things about Dr. Logan, and I have just had no problem. I just am amazed that you can have a hip replacement and recover so well. When I woke up, my hip pain was gone, and I had been in some horrible pain. But 30 minutes after I got in my room, I said, can I get up? And I've hit the road running, and I've been going ever since. And anybody in here that is thinking about hip replacement, Dr. Logan is the man, and Newberry Hospital is the place. And don't be scared. And you need to do it and share it with other friends that might need. And you do knees too, don't you? Yep. You just do everything. But I just can't say enough nice things about the people in Newberry and the doctors. Wow.
Thank you.
And you still look awful young. And plus, he has such a good sense of humor. I asked him when he told me he had done more of this procedure than any other doctor. And I said, but you look so young. He said, it's the olive oil that I use on my face. And one more little thing, this is very important to me. A lot of people from out of town, his nurse had told me this when I went to see him for that first visit, that a lot of times people from out of town, their ministers or church family can't be there, and I firmly believe in the power of prayer. And she said, Dr. Logan will ask you, do you mind if he has prayer with you before your surgery? And I thought, wow, that's neat. But I was very blessed. I had my minister, Dr. Logan, and my minister of music were there. But then I started thinking, I'm glad those other 2 guys were there, because is he praying that he doesn't mess up, or what is he praying about? But he is a good, caring, skilled Christian man, and I can't think of anybody that I would rather have doing surgery on this old woman. And thank you so much.
Well, thank you.
Yes, sir. Yes, sir. And he's a hugger too. Anyhow, thank you. I hope I didn't embarrass you.
No, you're great. You're great.
I'm subject to tell it like it is.
I appreciate it. Well, thank you so much. All right, so next we have Yvonne Howard. She's another patient of mine. She's had her hip replaced, and then she's also recently after a knee replacement because she was. So we're going to let her kind of give her experience as well.
I am from Columbia, live here, and I have been taking care of my father, who recently passed away, but I've been taking care of him for 8 years. So if you've been a caregiver, you know how tough that is. I was not able to exercise. I was not able to go anywhere. I lived with my father and worked in the same condominium every day. So I was getting no exercise. I started going to a surgeon in Columbia, hoping that he would help me with my hip and my joint pain. And I went to him for over 1.5 years, a man with a decent reputation, I thought, good words about him in the community. And he basically finally, after 1.5 years, told me, I will never do hip replacement on you because of your weight. Now, that was 1.5 years. I went to him and paid him money, and he was not willing to do hip surgery on me, and yet I was walking bone on bone according to his x-rays. So I was extremely disappointed, and I decided really to work on my weight really hard. I lost 44 pounds. I worked really hard, and then I went back to him and was so excited. Look, I've lost 44 pounds. Can you do my surgery now? He said, no, you've got a long way to go. And that was the end of my relationship with that doctor, because I couldn't exercise. I was in too much pain. And so I heard reputation about Dr. Logging through a gentleman that I knew who was a large man who had hip replacement. And I called him and I said, who is this doctor? And he told me about Dr. Logging. And I went to see him, and 3 weeks later, he replaced my hip. And to this moment, he has not said one word about my weight. He's never asked me what I weigh. He's never weighed me. He's never said, gosh, you need to lose some weight. I think we all know that. The first thing out of his mouth the day I went in, the first thing he said to me, what can I do for you? And that is the epitome of this gentleman, this doctor. What can I do for you? He was concerned about me and concerned about my hip and the pain that I was in. And I tell you, I cannot say enough good things about him. The surgery was incredible, I think. Everybody said it was, and I had a great time. I got out of recovery, and an hour later, I walked 250 yards, no pain. I've never had pain 1 second since on my hip. Never. I went to therapy for 2 weeks. For what reason, I don't know. I had no pain, nothing hurt. I could bend, I could squat, I could do everything. So my pain was gone. And after 8 years of being in constant pain, nobody will ever understand how that felt to not have pain. I was so excited about what he did for me that I asked him to x-ray everything else. What else can you do? And so he did my hip April 14th. He did my left knee October 5th. And so I'm waiting for other parts to give out, and I'll be right back with him. And I can only say I have one disappointing thing about the whole hip surgery. I need to be honest with y'all about that. I went in knowing what he was going to do, that the anterior approach was the best, and I had the best doctor on the planet to do it, the most caring man, the best hospital on the planet, the incredible staff and nurses there. I love Newberry Hospital, but yet I came away with a size 20 hip. I went in for a size 8 hip. I did not get the size that I wanted, so this is what you get today. But I'm telling you, I cannot sing his praises enough, and the surgery that he performs, anterior hip, is the way to go.
Thank you.
Thank you.
All right. Well, I appreciate both of you taking the time to give us your point of view with anterior hip replacement, and then with also Newberry Hospital. All right, so we've told you how good it is. They've told you how good it is. So if it's so good, why aren't there more surgeons doing it? And so that's usually everybody's question. And there's numerous reasons for that. One, it's different. It's out of a normal person's comfort zone. Okay, so it's technically more difficult. It's a lot harder to do. And in order to learn how to do it, because not a lot of people do it, you have to take time out of your practice, go learn how to do it, travel somewhere else. And most surgeons aren't willing to do that. They're too busy. They don't want to take the time. They say, well, my patients do fine the way that I do it. And so they don't make the effort. And if some of them try to go learn how to do it, they realize, well, it's just pretty hard. I don't know that I want to tackle it. and so they just give up on it.
Dr. Logan, where did you go to get that special training?
Yep, so before I even came in private practice, I was in residency at the time. I did my residency in Greenville, but there was nobody in Greenville, obviously in South Carolina, that was doing it. So I went to Charlotte in North Carolina and studied with a guy there multiple times. I went to Savannah, Georgia with a physician there multiple times. And then I also went to probably at least a half dozen or more cadaver training courses before I even got out of residency. So, which was good for me because before I ever operated on my first patient, I had probably seen the surgery done over 100 times. So I had a lot of exposure to it. And the problem, with some surgeons who say, well, I'm going to learn how to do it, and they go to a training course for one weekend, and then they come back, and then they feel like they're ready to try it, that can be a problem because it does take time to become proficient at it. The other issue with it is that there's a huge learning curve. To learn how to do it, it takes multiple patients, multiple surgeries under your belt before you can really feel comfortable with it. And studies have looked at that with anterior approach and the complication rates and what's the learning curve and how many surgeries does it take to become comfortable. And it's really between 50 and 100 surgeries for a surgeon to become comfortable and have a complication rate that's back to the normal level. So, with that said, experience does matter when it comes to anterior hip replacement. So you don't necessarily want to go to a guy who's just started doing it. And I'll give you an example. There was a hospital in the Midlands area where their surgeon decided, okay, I'm going to start learning how to do anterior hip replacement. And I'm not sure what training he went to. The hospital bought him the special table, which is pretty expensive, and he did 2 patients. And apparently had bad complications as a result of it. And the hospital came back and said, you can't do that surgery anymore. And they sent the bed back to the company. Just because you went to a training course and you learned how to do it doesn't mean that you're going to be good at it, because it's really hard to do. I've been doing it for 11 years and I'm really good at it now. But when I first started, it was hard, and it took me a while to get proficient at it. But I feel like I'm really good at it, and my patients do really well as a result. So you want a surgeon who's been performing it for some time. You want them to have at least done 50 or 100. So it's good to ask that question, how many have you done? Make sure it's at least 50 or 100, because usually most surgeons have become comfortable with it at that point. And if somebody struggles with it, they usually have given up doing it by that point. You also want somebody who exclusively performs it. And that's what I do. Anybody who comes in needs a hip replacement, I do it anterior approach because it's the better way to go. After I got somewhat comfortable at it several years ago, I tried to teach other physicians around me in Greenville and physicians I know how to do it. And they started doing it. And of probably the 5 physicians that I trained or taught how to do it, I think there's only one that still does it, but he does it intermittently. He does it on certain patients that he knows will be easy, and he doesn't do it on the hard ones. And to me, that's just a disservice to the patients, because it's such a better way to do it. And why are you going to subject some patients to a harder recovery and then some, because they're thinner or less muscular or whatever, to do it anterior? And so usually when you find somebody who only does it intermittently, they're not really comfortable with the procedure. They haven't mastered it yet. They don't feel good about it, and so they don't do it on everybody. And that's somebody that, in my mind, is just not the person to be doing anterior hip replacement, because if you're a believer in it and you're good at it and you see the results of it, I can't see why you wouldn't do it, because you're doing a disservice to your patients if you don't. So with that said, anterior hip replacement is really the only truly minimally invasive hip replacement that exists. It allows for a much faster recovery, ability to get back to your normal active lifestyle quicker, and you have a choice in how your hip's replaced. You don't have to settle for whatever surgeon you go to for what they tell you. You need to ask, hey, how are you replacing my hip? Do you do anterior approach? How many have you done? Ask those questions, because, I find most people put more effort into researching the car they buy than they do for their healthcare concerns. A lot of times they just do what their doctor tells them and don't research it. But you need to, because you have a choice and you don't have to settle for the long road to recovery. You have the opportunity. You can take the exit, have a shorter recovery, and choose anterior hip replacement. So I'll be happy to answer any questions that you may have about the surgery or anything in particular about the hospital at this point, if there's anybody who has any questions. Sure.
A list of questions.
Yeah.
If anybody else wants to ask first?
Sure.
I'll certainly have no problem with that.
Yep.
First thing, and this may be a K question versus a U question, Dr. Loggins.
Sure.
The HANA table, that's the specialized table
Yep.
that your hospital bought for your surgeries. Is there an additional cost to that to the patient, or does your Medicare normally reimburse the cost for that table as part of the hospital bill?
Yeah, so when you, from insurance standpoint, so whether you're private insurance, Medicare, or whatever, there's no designation of whether you get an anterior approach or a posterior approach or what approach. It's just, I had a hip replacement. So from a patient standpoint, because it's so much better, I don't charge twice as much or bill twice as much. It's just a hip replacement. So whether I do it the posterior approach or anterior approach, it's the same. So there's no extra cost or bill. They don't even bill for the use of the bed. That's just they realized, fortunately, when I came, 11 years ago, they said, okay, well, we're going to invest in this bed. We're going to put this money out with no chance of really getting the money back from billing other than just to help the patient. So there's no extra charge for that.
Okay. Is the prosthesis used for an anterior approach different than the prosthesis used for a posterior or a lateral?
Yeah, when you talk about implants and prosthesis, we have a model of the one that I use back there, so I think Brenda's going to bring that up and you can take a look at it. There are numerous different implants, and so the implants that I use can be used for posterior approach. It's not necessarily the implant itself, it's the instrumentation that allows you to insert it that's designed for anterior approach. Because we have a much smaller incision and the bone's oriented in different locations, we have inserters that are curved certain ways that allow you to get the right angles to insert it. But that particular implant could be used for posterior approach, anterior approach, or things like that. And you could get overwhelming if you looked at the number of implants that are available out there. There's gazillions of them, and they all have different ways they fit the bone. And I do this one because it is easier for anterior approach, but I mean you could use other implants, and I've used other ones at times, but I think this is the best one for me, for my patients, and probably has the least complications to it. So
you mentioned complications with the doctor that tried to do the tube. What types of complications? If somebody's going to have complications from an anterior approach, beyond infection, and those types of things that can happen with any surgery, what types of complications?
Yeah, so if you talk about me and you say, okay, what are the most likely complications you're going to have with me as your doctor? Probably the most common complication you could get is irritation of the anterior femoral cutaneous nerve. Okay, so there's a skin nerve that runs by the outside corner of the hip, and because we're fairly close to that, it gets stretched a little bit. And so after surgery, people will say, I have this little bit of numbness on the outside of my thigh, which usually resolves after about 6 to 9 months if you get it. Okay, so that's not necessarily a bad complication because it's a little bit of numbness. Even if it persisted, most people say it doesn't bother them because it's just numbness, it's not pain.
Not radiating pain.
That's correct. It's usually, and that usually does resolve though after 6 to 8 months or so. For me, that's probably the extent of the complications. I mean, I don't have a lot of them anymore, knock on wood. I mean, they could happen at any point. The physician that I talked about, he had 2 complications. He lost excessive amounts of blood. And that's part of knowing how to do it. There are certain blood vessels that you have to pay attention to and take care of on your way to do the hip replacement, and if you don't, they bleed like a water hose. And so obviously they're not familiar with where they are, and so they lost a lot of blood. And the other complication they apparently had is they cracked the femur. So when they were trying to put that stem down inside the thigh bone, they broke it. And that's a problem because then you don't have the support for the stem anymore. You have to put cables and wires around it to try to hold it together, limit how much weight they could put on it, and so that just creates a disaster. So those are other complications. I typically don't have those. Blood loss is really not an issue. I can't remember the last time I've had to even give somebody a transfusion after a hip replacement, so the risk of that's pretty low. And we take a lot of precautions to help minimize any complication. Obviously, infection, blood clots are a risk, but I can't remember the last one of those we've had either. Newberry Hospital has an extremely low infection rate, which they take good care of. I'm trying to think. Dislocation after hip replacement is always a risk or possible complication. That's highest with posterior approach because you cut the muscle that doesn't have the stability. That hip can pop out of place. It could still happen with anterior approach, but it's very difficult for it to happen because you don't cut the muscle, the hip has the normal stability to it, and so the hips usually don't dislocate.
Is someone with osteoporosis more likely to get into, for example, the head of the femur fracturing during surgery, or is that not an issue?
Well, that complication would exist regardless of the approach you do. You can crack a femur or break a femur when you're doing it posterior, so that could happen. I do all of my elderly hip fractures anterior approach as well because I feel, well, if it's good enough for a hip replacement, why is it not good enough for an elderly patient who has a hip fracture? So all of my hip fractures are done by anterior approach as well, and I do believe, and I'd love to do a study that proved it, but that they recover faster as well from a hip fracture than they would from the other approaches. And almost all of those patients have osteoporosis, which is why they get a hip fracture, and they do great with that too. So the stem that we use works really well regardless of osteoporotic bone, or patients with normal bone. So.
In terms of the surgical time itself, is it greater with a posterior versus anterior, or is the anterior more delicate? I realize you're not cutting through as much muscle. Which one requires more surgical anesthesia time?
Yeah, and that answer to that question is dependent on the surgeon you go to. And so, just like anything, if I gave everybody in here a task, it's going to take, some people are going to finish it in 10 minutes and some people are going to finish it in 2 hours. And surgeons are the same way. I'm pretty proficient at doing it. And so for me, it's routinely an hour. Sometimes it's shorter, sometimes it's a little longer, but it's pretty much right in an hour. I'm pretty reliable on that. If I were to do a surgery posterior, it'd still probably take me about an hour. So, but you got to ask questions though, because like some people who aren't comfortable with the surgery who try to do an anterior, and early on, that's one of the things they look at with the learning curve. It's not uncommon for people who are just starting out to take them 2 to 3 hours to do an anterior approach hip replacement because they're not comfortable with it. So a lot of that depends on the surgeon. For me, it's an hour, and I don't think this. For me, a surgery time wouldn't be that much different. And somebody who's good at a posterior approach probably would take them about an hour or so. So I think surgery times are different, but you do have to ask about each surgeon's different. And so some people take longer to do things, but if somebody's taking 2 to 3 hours to do a hip replacement, yeah, that's a little long. Because the longer you're in there, the increase your chance of infection, increases your chance of blood loss, needing a transfusion, and all those other potential problems. And so I think you shouldn't be going much over an hour if you can help it.
Then my last question.
Sure.
What's the timeline until you're able to drive? I know that's going to be individualized, but generally speaking, is it that 1 week, that 2 week, that 3 week, that 4 week?
Yep, and that depends on which hip you have replaced.
That's your right hip.
Yep, that's correct.
That's your driving hip.
Yes, if you have your left hip replaced, I have patients who have driven in 1 to 2 weeks. Okay. Really as soon as you're comfortable getting in and out of the car, then you could probably drive, and then obviously off your pain medication. They really have you getting in and out of the car, as you saw, because they have the car there in in the hospital. They need to get like a video game and you could sit in it and play, but that may be the next thing they invest in. If it's your right hip, usually I tell people you need to be off the walker, which is usually 1 to 2 weeks. You can be using a cane as long as you're comfortable getting in and out of the car. I usually tell people it's 3 to 4 weeks with the right hip because I want you to be able to slam on the brakes if somebody pulled out in front of you. And to have that control to do that usually takes about 3 to 4 weeks.
Okay. I think you answered them all. Thank you very much.
Great, sure. Yes, sir.
My problem with the hip was avascular.
Yes, sir.
Is that surgery treated any different from other causes?
Yeah, so surgery to do for avascular necrosis versus arthritis is essentially the same. Typically, we talked about resurfacing. Resurfacing is truly bad for people with AVN because they don't have the bony support to put the cap over, so that would fail very quickly. But the hip replacement itself would be very similar to the for arthritis. We go in and we remove the ball out that has the AVN in it and then do the replacement. And I usually find AVN patients, because that's really painful condition, those patients do really well with that.
One other question, the accuracy leg damper control, could you explain that to me?
Yes, sir. I'll go back here with the talk. So what we do with determining the leg length, so if you've got AVN in a hip and your leg's really short on that one side, or even if you had an injury as a child and you're short because of another reason on one side, what we do is we use the x-ray machine. And so you can see this x-ray machine here we use during the surgery that allows us to look at the hip. And so we can look and see where these landmarks of the hip relate to the pelvis. And then we can use your other side as long as it's normal, and if it's not, so say you had AVN on both hips and you're going to need a hip replacement on both sides at some point, we can make this leg whatever we want and then we could correct it when we do your other side. But if this other side's normal and we're replacing this one, what we do is we measure, we take these x-rays on both sides, we measure the landmarks around the hip. This is the lesser trochanter, the greater trochanter, and the rami of the pelvis, and we draw lines across that. And then we do the same thing on this other side. And so we can see where the line goes on the bottom of the pelvis and where it intersects the lesser trochanter on either side. And as long as that line matches on either side, the leg length should be fairly equal. And we also use your x-ray before surgery, so we see where all those landmarks line up before surgery. We measure your legs and say, okay, you're an inch short. And this is what your x-rays looked like before. We correct that, and then we get your legs pretty close to even, or at least so close that you can't tell the difference within it.
Thank you.
Yes, sir.
You may probably just ask, I'm sorry I had to work late.
That's okay.
My leg's pushing out this way, and my left leg, and they said it's all probably because of my hip. Mm-hmm. Does that happen a lot? Does your leg go that way?
It can, yeah. Where you externally rotate your foot, you turn your foot out, is what you're saying? Or?
Yeah, and it won't go back.
Right.
I used to make it go back, and now it just sticks out.
Yeah, so if we look back to like hip arthritis, if you've got a condition like this, that's AVN, or even arthritis where you've got spurs around the hip, a lot of times what will happen is as the deformities occur, the spurs form within the hip, those start limiting motion. And so you can get to a point where your hip is turned out because of the deformity that's there or the spurs that are there, and you can't get it back in because there's a mechanical block to it. Usually surgery will correct that because that mechanical block is removed, and then it'll allow you to regain normal mobility hips. Pretty common for patients with AVN or hip arthritis to say, I can't put my socks or shoes on anymore because I can't get over to get down to get to my foot. And that is usually taken care of with the surgery as well. So most patients after surgery, they have to work with therapy to stretch it back out. But because all those bone spurs or the deformities taken away, they can get back to a point where they can put their own socks or shoes on again.
Okay, thank you.
Sure.
Dr. Logan, what can we do to make people know about you? So many people really missed an opportunity tonight.
Right.
What can we do to get your name out there and get people to Newberry?
Well,
when is your...
Yeah, the Chapin office should be open in November of this year, so we got a few months before it's going to be open. But it'll be a really nice facility once it is. The big thing is I tell patients, because I care about people and their recovery, and it's not about me and how busy I am or any of that. And so if you come to see me, great. I'm happy to take care of anybody that's out there. But if somebody needs a hip replacement, if they didn't want to come see me, that's fine. But I really encourage them to go to somebody who does anterior hip replacement, because I would feel bad that they went somewhere else and had to have a harder recovery by a posterior approach. So me in and of itself, I think the biggest thing is just educating people that you know about anterior approach. And if that leads them to me, then great, and I'm happy to help take care of them. You know, the easiest way is word of mouth. Anybody that you know of that needs it, tell them, hey, anterior approach is the way to go. And I'm the closest person around that does it, and I've been doing it longer than anybody else in South Carolina. So, you know, I'm happy to take care of those patients. You know, outside of that, I'm not sure how else to get the word out. I mean, I've been trying to get the TV stations in Columbia, which we talked about, to kind of make people aware. And we're going to continue to work with that, because it is a disservice and it's sad for patients who go through it every day. One of my patients was supposed to come but didn't make it. She had one hip done here in Columbia one way, and then we replaced her other hip just a few weeks ago. And those are the patients who can really tell the difference, who've had one done one way and then have the other one by anterior approach. I've even done patients who've had hip resurfacing here in Columbia, and then they come to me for their hip replacement on their other one. Even they say, oh my gosh, it's night and day difference. And they get mad, because then they go, wait, when I had my other hip done, you were here doing it? And I said, yep. And they said, well, now I'm mad because why didn't I get to come to you then? And I'm like, I don't know. You know, and this is why I'm here, trying to get the word out that, you know, this is a better way to do it, because it truly is, and it makes a huge difference in recovery. You don't have all the pain from surgery. And so, you know, telling anybody you know who needs a hip replacement, if you've got organizations that you know of, church groups, things like that, that want me to come and talk to them about it, we're happy to come, because we're doing everything we can to just make people aware of anterior hip replacement and how much better it is.
Well, I want to share a little side note. This is so rare. When the first time I saw Dr. Logan, I asked him, could he save my hip joint, that I wanted to see what bone on bone and bone spurs look like. He said, no, I can't do that, but I'll take pictures. And this nice man took time from his busy schedule to send me an email with a picture of my hip joint that he took out of me and explained all this. And I just thought, how many surgeons take time to do something like that? And we've emailed back and forth, and I just can't say enough nice things about your caring level is through the roof.
Well,
and I'm so glad I found you.
Well, I appreciate the kind words. You know, I just treat people like I'd want to be treated, and so, yes, sir.
I'm probably late, you might answer this, but
Yep.
my leg is going out, and I understand I need new hip. That's why I'm coming to talk to you.
Yep.
And why does it hurt? It hurts me limping around, like really about 7 out of 10 pain level. But as soon as I get up, first thing in the morning, when I go that little distance to the bathroom, it is like 10 or 11 out of 10. And when I get out of my car, for that first 10 yards, it's 10 out of 11 pain.
Right.
What makes that do that?
Yeah.
Is part arthritis?
Well, it's part of it, but you know, the inactivity, so sitting in the car for a period of time, the laying in bed for a period of time, that hip stiffens up. Yeah, and so it starts to get really stiff because you're not moving it. And then once you get up to start moving, it's really stiff. Things are kind of tightened up, and you got to re-stretch that back out. So it starts to feel better once you get moving because things have stretched back out. But usually, yeah, those first few steps, or you know, first few minutes of when you first get up either out of a car or in the morning, the pain's usually worse. That's a pretty common problem with arthritis or you know, joint problems like that.
I'm sorry you missed all this, sir.
I know. I had to work. I could not leave work.
That's okay. I can review it with you afterwards if you want to see it. Sure.
I would like to talk to you.
Yep.
He's the best of the best, and the hospital is the best of the best, and you won't have any more pain with me. You'll be hopping along.
Thank you. That's great. That's why I'm here.
Any other questions?